So we'll move on to our last talk of the session.
I will invite now Dr. Samendra, and he is going to be telling us more about masquerades. When everyone thought it was non-responsive uveitis, the enigma and dilemma of a masquerade.
Thank you so much, ma'am. So you've already set the ball rolling, ma'am, and I hope I can add a little bit more to it. Good afternoon, everyone. Masquerade is basically a term which is often used in terms of a cancer presenting as uveitis. But with this presentation, I'd make it clearer that it is not just cancers, and it has much more than the eyes can see. So mask is something that hides the real identity. So in uveitis, what are the things that hide the real identity of a uveitis or present as uveitis, but it is not? So there are two basic subgroups of masquerades. One is a non-neoplastic subgroup, which all of us come across in our practice. A trauma, intraocular foreign body, which present with cells, they can present as masquerades because they are not autoimmune in nature. Pigment dispersion, so the cells are pigmented cells, again, present like uveitis. Retinitis pigmentosa has cells, again it's not uveitis. Ocular amyloidosis, ocular ischemic syndrome, rhegmatogenous RD, all of them have cells, but they are not primarily uveitis. So the idea when we deal with these kind of entities is to know what kind of cell we are dealing with. Whether we are dealing with a white blood cell, a red blood cell, pigment epithelial cell, RP cell, or a tumor cell. And with the modern slit lamp with high magnification, it is quite possible to differentiate what kind of cell you are dealing with. This another subgroup of masquerades are the ones which we come across in neoplastic entities. So they can be primary intraocular lymphoma, primary vitreoretinal lymphoma, primary uveal lymphoma, leukemias, or metastatic solid tumors. And in children, we come across retinoblastoma, like ma'am just showed in the previous case, Coats, juxtaxanthogranuloma, and medulloepithelioma. So this slide basically gives an overview of the ocular lymphomas. So they are primarily either anatomically they can be divided as iris, ciliary body, choroid, or the ones involving vitreous body, retina, or optic nerve. So the ones which involve the iris, ciliary body, and choroid can be grouped as uveal lymphomas, which could be primary low-grade lymphoma or secondary from a systemic high-grade lymphoma. The posterior segment involving vitreous body, retina, and optic nerve are grouped as vitreoretinal lymphomas, of which primary vitreoretinal lymphoma is the one which we often see in our OPD, where the first presenting sign is actually the vitritis or the cells in the vitreous. Others can be ocular involvement of primary CNS lymphoma, where the entity begins in the CNS and then involves the ocular tissues later, or a secondary from a diffuse large B-cell lymphoma. So just to illustrate what I've discussed, I'll show a case where a 65-year-old Asian Indian female presented to us, and she had a complaint of diminution of vision and floaters for a year, insidious, gradually progressive. She was a hypertensive, rest of the systems were normal. She had multiple consultations in several clinics, but there was transient or no relief at all. Several courses of topical oral steroids, including PST. So everywhere she went, the next physician gave her a newer modality of steroids. She was even diagnosed with both eyes primary angle closure glaucoma, chronic iridocyclitis, and laser PI was also done. And currently, when the patient presented to us, she was on anti-glaucoma medication. The vision was 618, 69, pressures were moderately controlled. She had KPs, pigments on endothelium, and some cataract. She, on fundus examination, she had dense vitreous membranes with vitritis, which were more in the right eye compared to the left. We subjected her to a thorough uveitis workup, which turned out to be negative. This is the anterior segment. Although we did give her some topical steroids, we didn't want to hurry or rush into giving her oral steroids because she had received so many forms of steroids already. So this is the picture after topical steroids. The fundus shows in the red glow that there are some vitreous membranes, some pigment depositions on the endothelium. The FFA wasn't much revealing because of the dense vitritis in right eye, and left eye showed some faint vascular staining. This is the clinical course. The IOP remained controlled. However, the vision kept on deteriorating in front of our eyes. She had large mutton fat KPs initially, with dense vitreous membranes. So we were a little confused whether she's having uveitis or she has pigment dispersion glaucoma. We were really not sure, but we knew that we are dealing with something unusual. At this point, we started thinking that this is not the run of a mill entity, and we need to start thinking of unusual entities. And this is the first time when I thought, because she is an old lady, non-responding vitritis, thought of primary vitreoretinal lymphoma. We planned a vitreous biopsy, and so this is a brief video where we did a vitreous biopsy. We generally do our biopsies under air so that we can receive pure vitreous. So the yield or the PCR yield becomes, or the cytology yield becomes much more, because we have received a pure sample and not a diluted sample. So as the air bubble keeps expanding from the infusion, we lower our cutter and keep going back as we reach close to the retina. And when we have we can get about 0.4 ml sample with this technique quite comfortably. You can see some fluffy deposits over here, this area. So apart from this, there was no other finding in the fundus. So we subjected it to cytology, and we saw some large cells with hyperchromatic nuclei and scanty basophilic cytoplasm, but the diagnosis was not very clear. Anyway, we subjected her to neuroimaging. MRI brain was reported normal, and left eye vitreous biopsy also we did, which was also reported normal. So right now, we had no clue what we were dealing with. Patient was exhausted, and she did not follow up for some time. However, she came after a couple of months with recent onset forgetfulness and left-sided headache and periorbital pain. The ocular exam was okay. I again told her to go and consult a neurologist and get an imaging done, which they refused because they had just got an MRI done 3 months ago. Patient probably went back home at this stage. Then, not so much to our surprise, patient landed back in emergency just after about 15 days with left side hemiparesis and slurring of speech for 5 days. Emergency CT scan revealed this large lesion in the left brain. Immediately, the patient had to be taken up for neurosurgery because there was some uncal herniation which was associated. The squash cytology suggested a neoplastic lesion with morphological features of high-grade malignancy. Tumor biopsy and histopathology showed the neuroparenchyma, which was diffusely infiltrated with neoplastic lymphoid cells. Immunohistochemistry confirmed our doubt, and it was a LCA positive CD20 B cell and negative for CD3, suggestive of a right temporal diffuse B cell lymphoma. Finally, the diagnosis was made, and the patient was diagnosed with high-grade NHL B cell lymphoma, currently receiving radiotherapy and chemotherapy, and patient is doing well. We didn't feel the need for any intravitreal methotrexate because there were absolutely no lesions or findings in the fundus. So all cells are not inflammatory. There has to be a very high index of suspicion for picking up masquerades. In the era of MIVS, we shouldn't hesitate to take a sample, and we should always believe in our clinical judgment. Thank you so much.
So thank you, Samendra. I think my talk and your talk both have done the job, that everything is not uveitis. And we have to be very observant and careful if a patient that we had diagnosed as uveitis is not responding to steroids and to immunosuppressants. And I think both of us have highlighted that it's time to revise the diagnosis. Either we take another opinion or do an interventional diagnosis in the form of vitrectomy. And I think you've beautifully highlighted again that it's good idea to collect an undiluted sample with an air infusion. If you're dealing with or having a suspicion of lymphoma, then we have to stop steroids at least 14 days prior to taking the vitreous sample, and transport those samples very fast to the lab because the lymphoma cells are very fragile. And unfortunately, all of us do also face this problem in our clinics, that despite we having diagnosed lymphoma, the neurologists don't believe that the patient is having lymphoma, and we've all lost a few of our patients because of late diagnosis and late management. But I think this is something we all need to keep in mind, and we have to be careful before, it becomes fatal. So any questions from the audience, we would be very happy to take them up. So Samendra, would you like to wind up the session?
So thank you all so much for being part of this IC, where we dealt with the basics of uveitis all the way to masquerade. And thank you so much for Dr. Manisha ma'am and Dr. Padma for their expert comments and the analysis of the cases and the talks presented by us. Thank you all the speakers, Dr. Nitin, Dr. Mudit, and thank you AIOS for giving us this opportunity. Thank you all so much.
Thank you so much.